Good afternoon to all of our participants today. First of all, I would like to thank the UPPGH Division of Hematology for this opportunity to talk about leukemias. Specifically, our topic for today would be about when an elevated white blood cell count is considered leukemia. These are the objectives of my talk. So let's start with a few cases. Our first case is a 55-year-old female coming in with a chief complaint of leg pain. She was referred due to an abnormal CBC, wherein her white blood cell count was markedly increased to 152 times 10 to the ninth per liter. The differential count showed apparent lymphocytosis. She was also complaining of shortness of breath. Our second case is a 76-year-old female, asymptomatic, referred to by her endocrinologist because of persistently elevated white blood cell count of around 40 times 10 to the ninth per liter. Again, her differential count showed a predominance of lymphocytes. Lastly, case 3 is a 55-year-old male who was also referred due to an increased white blood cell count of around 30 times 10 to the ninth per liter. In this case, the differential count showed a predominance of segmenters. So first we define what is leukocytosis. Leukocytosis is defined as an elevation of the white blood cell count for the patient's age. And in this table, we can see the normal values per the age of the patient. So for adult patients, the usual normal range is 4.5 to 11 times 10 to the ninth per liter. And this normal value is slightly increased in pregnant females in the third trimester. Now, when we talk about the white blood cell value, this represents the sum total of white blood cell subtypes, including neutrophils, eosinophils, lymphocytes, monocytes, basophils, or even abnormal leukocytes that are not typically found in the peripheral blood smear. The clinician should properly characterize the leukocytosis and determine if further evaluation and workup are necessary. So in the bone marrow, the hematopoietic stem cell will differentiate into the common myeloid progenitor and the common lymphoid progenitor. The common lymphoid progenitor gives rise to the lymphocytes, while the common myeloid progenitor gives rise to the myeloblast, which in turn gives rise to the other white blood cells, the neutrophils, eosinophils, monocytes, and basophils. Leukocytosis can therefore be classified based on the cell line that is elevated. A complete blood count with predominantly elevated neutrophils is termed as neutrophilia, eosinophils, eosinophilia, and so on. The type of cell that is elevated may help to identify the trigger for leukocytosis, and a detailed history and physical exam is important to support the diagnosis of a particular leukocytosis. Okay, so the first step in the evaluation of patients with leukocytosis is to confirm the presence of leukocytosis, as we defined earlier. We also need to confirm if the reported differential count is indeed correct. So this is because not all CBC machines are created equal. Some machines, especially in level 3, hospitals, and big laboratories, can flag abnormal values and actually report atypical cells. However, in primary care centers and in some provinces, especially where I practice, atypical or abnormal leukocytes, such as blasts, are often counted as monocytes, lymphocytes, or even neutrophils. Therefore, in order to verify the veracity of the reported differential count, it is important to look at the patient's peripheral smear. As hematologists, we ourselves look at the peripheral smear. However, in areas where there are no practicing hematologists, you may ask the pathologist or the med tech to read the peripheral smear and ask specifically if they saw any atypical or immature cells. So we go back to our patient. Case 1. This is the peripheral smear of case 1. As you can see, these cells pointed to by the red arrow are bigger than the red blood cells surrounding them. And if you look at the slide, mostly the cells are predominantly of this kind. So these cells are described as large mononuclear cells with open nuclear chromatin and abundant cytoplasm. These are typical for myeloblasts. Typically, we do not see myeloblasts in the peripheral blood. So in this patient, she had a reported count of 95% lymphocytes, which were actually blasts. So these are actually blasts. Patient was eventually evaluated as having acute leukemia in leukocytosis, in hyperleukocytosis, and eventually workup confirmed the diagnosis of acute myeloid leukemia. Our second case had a peripheral smear that looked like this. So this is a 76-year-old female presenting with a symptomatic increase in white blood cell count. The predominant cells in this peripheral smear are the ones pointed to by the red arrow. So these are small, mature-looking lymphocytes. Also notable are the presence of cells that appear to be squished or destroyed. So these are the cells that are pointed to by the blue arrow, and these are called smudge or basket cells. So this profile, the elderly patient with absolute lymphocytosis in the peripheral smear, is actually typical of chronic lymphoid leukemia. And this patient underwent further workup and eventually showed CLL. Next, we have the peripheral smear of our third case. He had a peripheral smear that looked like this. The predominant cell in this peripheral blood smear is a mature segmenter. He eventually presented with progressive weakness, and further workup revealed that he had a metastatic hepatocellular carcinoma. And eventually, the leukocytosis was ascribed to a leukemioid reaction. So what is a leukemioid reaction? The values are actually different per source, but it basically means an increase in the white blood cell count. Some would describe it as more than 50 times 10 to the ninth per liter, but there's no real actual value. This should be in the absence of myeloproliferative neoplasm. This can occur in the setting of sepsis, organ rejection, solid tumors, and bacterial infections. The mature cells are neutrophils. The predominant cells are actually mature neutrophils, and usually the neutrophilia would improve after treating for the underlying cause. So now we go back to our algorithm. After confirming the predominant cell in the peripheral blood, we can proceed with further evaluation. Let's focus first on the left side of the graph. So if the predominant cells are blasts, then workup for acute leukemia should be done. This would include a bone marrow biopsy, a bone marrow examination for histology, morphology, flow cytometry, cytogenetic, and molecular studies as appropriate. Now we go to the right side of the graph. If you can see here, the predominant cells are lymphocytes. It is again important to look at the morphology. If the lymphocytes all look the same or they look monomorphic, then workup for lymphoproliferative disease should be undertaken. If the lymphocytes appear pleomorphic, then the cause can be a reactive. In the middle part of the graph, we have the myeloid series. So if the monocytes are the predominant cells, consider reactive causes secondary to chronic infections, malignancy, splenectomy, autoimmune disorders, or even a regenerating marrow post-chemotherapy or post-transplant. However, if there is significant dysplasia and presence of some blasts, then bone marrow study should also be done. If there is an increase in basophils, then one should suspect a myeloproliferative neoplasm. So testing for BCR-ABL, JAK2 mutation, bone marrow studies, and other tests may be done. If there is an increase in eosinophils, then this is usually a reactive cause. So we rule out any allergies, parasites, drug reactions. However, we cannot completely rule out myeloproliferative neoplasms. So if there is persistence in the eosinophilia, even after treatment, then we may need to do bone marrow studies, including cytogenetics and FISH tests for PDGFR. Now, in the middle of the graph, we have our neutrophils. So as we mentioned earlier, if there is a left shift in the neutrophils, we see toxic granulations, Dolly bodies, vacuoles, and it is PCR-ABL negative, then this is most likely a reactive cause of the leukocytosis, and we should work up further for infections, chronic inflammation, or other disorders. If the white blood cell count is more than 50, there is marked left shift, there is basophilia and dysplasia, then we should do bone marrow examination with ancillary tests as appropriate. So these are symptoms or findings that are suggestive of malignancy in the setting of leukocytosis. So if your patient presents with bruising or bleeding tendencies, if the patient has fatigue, weakness, fever, known to be immunosuppressed with night sweats and unintentional weight loss, these may be symptoms that may be pointing to a malignant condition. Hence, further workup is necessary. If the patient also has lymphadenopathies, petechiae, organomegaly in the form of splenomegaly and hepatomegaly, and most importantly, as we can also see in our patients, if the patient has decreased red blood cell count or hemoglobin and hematocrit levels, other CBC abnormalities, including increased or decreased platelet counts, a monomorphic lymphocytosis on the peripheral smear, and predominantly immature cells on the peripheral smear, then workup for malignancy should be done. When we go back to our earlier cases, case 1 again is a 55-year-old female presenting with leukocytosis. But if you look at her CBC, she also has significant anemia and thrombocytopenia. Again, this was diagnosed as a case of acute myeloid leukemia. Our second case is a patient who had an elderly woman who had a monomorphic lymphocytosis in her peripheral blood. She also presented with small lymphadenopathies in the cervical region. She was eventually diagnosed to have CLL. Now, for the initial workup of patients who are with a consideration of acute leukemia, this guideline is from the College of American Pathologists and the American Society of Hematology. So I'm just, for the sake of brevity, I'm just pointing out the strong recommendations. So of course, a history and physical examination is necessary, a CBC, differential count, peripheral blood smear, bone marrow aspiration and biopsy for morphology. You should also do karyotyping, FISH testing, flow cytometry, immunophenotyping. For patients with ALL who are going to receive intrathecal therapy, then a CSF sample should be obtained. For patients with extramedullary disease, a tissue biopsy may be obtained and it should be processed for morphologic, immunophenotypic, cytogenetic, and molecular studies. For patients with suspected or confirmed acute leukemia, we should ensure that flow cytometry analysis or molecular characterization is comprehensive enough to allow subsequent detection of minimal residual disease. For patients who have suspected or confirmed B-cell ALL or mixed phenotype acute leukemia, ensure that testing for translocation 922 or PCR-ABL is performed. For patients who have confirmed acute myeloid leukemia of N type, testing for FLT3 ITD mutation is also strongly recommended. For patients with CBF AML, RUNX1 or inversion 16 or translocation 16 AML, ensure that appropriate mutational analysis for KIT is performed. Unfortunately, I don't think we are able to do this in our country. For patients suspected APL, ensure that rapid detection of PML-RARA is performed. Order appropriate coagulation tests as well to evaluate for DIC. For patients other than those with confirmed core binding factor AML, APL, or AML with myelodysplasia-related cytogenetic abnormalities, ensure that mutational analysis for NPM1, SEBPA, and RUNX1 is also performed. So again, I don't think we're able to do this routinely in the Philippines yet. So for patients, let's now go to the different kinds of leukemias. First, we have acute myeloid leukemia. Acute myeloid leukemia is pretty common. It's more seen in elderly patients. It presents more rapidly than patients with CML. So in patients with AML, there is accumulation of genetic abnormalities in the original myeloid precursor cell or the myeloblast. And in the myeloblast, it stops maturation. So the myeloblasts just divide and accumulate in the bone marrow. This may lead to weight loss, malaise, fever, chills, and night sweats. The expanding marrow pushing on bone can also lead to bone pain, which is seen in some of our patients. Case 1 presented with leg pain, and this may be because of the bone pain from the expanding marrow. The blasts eventually displace other blood precursors from the marrow, so they inhibit the production of red blood cells, normal white blood cells, and platelets. This would lead to a decrease in the neutrophils, decrease in red blood cells, and decrease in platelets, as is seen in the peripheral blood of patients with acute myeloid leukemia. Because of the decrease in neutrophils, this leads to greater chances of infection. Decrease in red blood cells causes anemia, leading to fatigue, shortness of breath, and the decrease in platelets would lead to easy bruising and petechiae. So eventually, once the blasts in the bone marrow expand, they lead to more than 20% of bone marrow blasts, which is what we use to diagnose acute myeloid leukemia. So after the blasts fill up the bone marrow, they eventually spill out into the blood. And this is what is seen in the peripheral blood smear as blasts. So eventually, the white blood cells increase. This is counted as leukocytosis. The neoplastic cells may also secrete amounts of coagulation promoting cytokines, which leads to DIC, especially in patients with acute promyelocytic leukemia. Myeloid cells may also produce intracellular granules, which precipitate inside immature blasts to form rods, and these are what are seen as our rods on the peripheral blood smear. Because of the high turnover of these cells, there is an increased rate of cell lysis, and there is a release of intracellular contents, including uric acid, potassium, and LDH into the plasma, causing hyperuricemia, hyperkalemia, high LDH, leading to tumor lysis syndrome, AKI, and even gout. So these are the 2022 ELN recommendation for the diagnosis of AML in adults. For blood and bone marrow tests, a complete blood count, bone marrow aspirate, trephine biopsy, and immunophenotyping by flow cytometry is required. Genetic analysis, including cytogenetics and screening for gene mutations, especially FLT3, ITH1, MPN, SEBPA, and the others. And then for recurrent gene rearrangement such as PML-RARA, core binding factor, RUNX1, KMT2A, PCR-ABL, and other fusion genes. So not all of these are available in the Philippines. We have FLT3, we have PML-RARA, PCR-ABL, but the others are not very easily available. Of course, a medical history is necessary, including the comorbids of the patient, because this is needed for deciding what is the most appropriate treatment later on. Again, physical exam, determining performance status of the patient, geriatric evaluation, biochemical coagulation tests, testing for infections that might become reactivated with treatment, including hepatitis, HIV, CMV, EBV, HSV, DSP. Pregnancy, of course. We should also test for eligibility for allogeneic transplantation, and then the other tests. So this small table shows us the risk category according to the ELN risk classification by genetics. So usually patients with intermediate or adverse cytogenetic abnormalities are referred for consolidation transplant. So this is a basic timeline of AML treatment from diagnosis to the consolidation. So initially, after initial diagnostic evaluation and lab workup, we assess the patient's eligibility for transplant. So patients with intermediate or high risk AML should be referred to a transplant physician at diagnosis. And then we start induction therapy. So induction therapy is usually lasts for about 7 days, and the resolution or recovery lasts for about 2 to 4 weeks. The appropriate consolidation therapy will depend on the risk stratification of the patient and if transplant is indicated for this case. So the usual treatment for AML would be the usual induction. If there are no other qualifiers, would be the usual 7+3 treatment. If the patient is FLT3 positive, then addition of midostaurin. If the patient is CD33 positive, then optional addition of gemtuzumab. If the patient has secondary AML from another myeloid disorder, then liposomal daunorubicin and cytarabine may be a good approach. So patients who have an FLT3 ITD mutation, an intermediate or high-risk AML disease profile would usually be referred to transplant. So now we go to the next kind of leukemia, which is acute lymphoblastic leukemia. So again, there is an arrest in maturation at the blast level. So there is an accumulation of genetic abnormalities in the immature lymphoid precursors, so either B or T cell precursors. These lymphoid precursors divide and accumulate in the bone marrow, and again causes the same symptoms: weight loss, malaise, fever, night sweats. And because of the expanding marrow, this will also cause bone pain. This is actually worse than those that patients with AML feel, and is more common in children. Again, if there is proliferation of the blasts in the bone marrow, this leads to a decrease in the growth of the other cells. So there is decrease in the neutrophils, red blood cells, and platelets, again leading to greater chances of infection, fatigue, shortness of breath, and bleeding tendencies. So after the blasts spill out the bone marrow, they spill out into the blood. These blasts may accumulate in the lymph nodes and the spleen, which may lead to lymphadenopathy and splenomegaly. Again, we see the blasts in the peripheral blood, and this may present with leukocytosis. However, actually patients with ALL may also present with pancytopenia. The high turnover of these cells will lead to a release of the intracellular contents, including uric acid, potassium, and LDH, again leading to tumor lysis syndrome, acute kidney injury, and gout. So for the diagnostic workup of patients with ALL, according to the ESMO-CTG done in 2016 or 2017, there should be adequate morphological studies of the bone marrow, peripheral blood, and cerebrospinal fluid. Immunophenotyping covering MPO, B lineage markers, T lineage markers, and stem cell markers should be done. Cytogenetics, minimal residual disease markers, storage of diagnostic material, and HLA typing may be done. MRD not very much available yet in the country. Storing of diagnostic material, unless it is in a clinical trial setting, we don't usually have that in the Philippines. According to the NCCN guidelines for ALL, again, morphologic evaluation of the bone marrow, peripheral blood, CSF may be done. We should do immunophenotyping, baseline flow cytometry, MRD analysis, karyotyping, molecular characterization, very important to do RT-PCR testing of PCR-ABL, as this is the most common genetic mutation in patients with ALL. Next generation sequencing, again, not yet readily available in the country. So this is just a general algorithm of how treatment for ALL ensues. So we have the diagnosis of ALL, we get the morphology, immunophenotype, a PCR for BCR-ABL, we get the risk stratification, cytogenetics, and then we start a pre-phase with some steroids for about 5 to 7 days, and we start induction therapy, which lasts for 4 to 8 weeks. After this initial induction therapy, we assess the risk if there is good response or if there is poor response, and we will decide whether allogeneic transplant or chemotherapy consolidation is necessary. So after consolidation, which usually lasts for about half a year to a year, there is also a maintenance therapy that lasts for about 2 years if the patient does not undergo the allogeneic transplant. So in general, chemotherapy includes induction therapy for 1 to 2 months, consolidation for 6 to 8 months, and maintenance for 2 to 2.5 years. Ongoing chemotherapy protocols for IAS use pediatric type regimens and prophylactic treatment to prevent CNS relapse is mandatory. Anti-CD20 rituximab in combination with chemotherapy, strongly recommended for Burkitt. Anti-CD22 immunoconjugates directed against CD22 are currently still under investigation. Anti-CD19 may be used. Bispecific CD3, CD19 blinatumomab is also presently under investigation. CAR T cell therapy against CD19 also being tested. Target therapy with TKIs in Philadelphia positive ALL. So a TKI should be combined with chemotherapy in the frontline therapy. A TKI, for example, imatinib, should be administered continuously even after transplant. Prolonged monitoring of BCR-ABL, MRD is recommended as well as resistance mutations screening. Transplant, allogeneic transplant in CR1 significantly improves overall survival and event-free survival in high-risk MRD positive patients and is the best post-remission option for Philadelphia positive and MLL rearranged ALL. Okay, so now we go to CML. Chronic myeloid leukemia happens when there is a translocation of chromosome 9 segment into chromosome 22, creating a Philadelphia chromosome containing the BCR-ABL fusion gene. In addition, there are other mutations from ionizing radiations and other genetic abnormalities, which eventually accumulate in the blood cell differentiation sequence in the pluripotent hematopoietic stem cell. The hematopoietic stem cell in the bone marrow becomes unregulated and eventually leads to chronic phase, chronic myeloid leukemia. So chronic phase is presents about 85% of the time. There is an increase in the hematopoietic stem cell division and differentiation in the bone marrow, leading to increased production of multiple cell lines, which is usually detectable on CBC. But most patients will actually be asymptomatic during this time. So they will present to the clinic with an incidental increase in the white blood cell count. We can see increase in thrombocytosis. There can be neutrophilia, basophilia, eosinophilia. There can also be a disorderly white blood cell differential, meaning a myelocyte bulge. These white blood cells eventually become trapped in the spleen, and this causes splenomegaly, which is typical for patients with CML. So as patients acquire more genetic abnormalities, this leads to the accelerated phase. So during the accelerated phase of CML, there are more and more immature precursor cells that divide and accumulate in the bone marrow. So usually these are 10 to 19% of cells are already blasts. Then blasts start to spill over into the peripheral blood. So here patients also have anemia, leading to different pallor, dyspnea, and tachycardia. As patients acquire more genetic abnormalities, this eventually leads to the blastic phase, which can be either myeloid or lymphoid. There are more than 20% blasts in the peripheral blood and in the bone marrow. Again, this may lead to gout, AKI, bone pain, and sternal tenderness. So for patients with suspected CML, a history physical exam usually will show splenomegaly, markedly increased white blood cell count, a bone marrow aspiration and biopsy with cytogenetic evaluation, and PCR should be done. Once the patient is classified into either chronic or advanced phase, then we proceed to doing risk calculation. And depending on the risk calculation on what kind and comorbids on what type of TKI we would start. So the common TKIs are imatinib, nilotinib, dasatinib, bosutinib, and ponatinib. In the Philippines, we have available imatinib, nilotinib, dasatinib, and ponatinib. So after treatment with these medicines, we have to monitor treatment response using the PCR. So this tells us the BCR-ABL transcripts at 3 months, 6 months, and 12 months. If at any point there is the patient falls into the red color, so this is actually concerning for TKI resistant disease. We should monitor, evaluate patient compliance and drug interactions, consider mutational analysis, switch to another TKI, and evaluate for transplantation. Last kind of leukemia, the most common kind is chronic lymphoid leukemia. So chronic lymphoid leukemia is most common in developed nations, but not so common in the Philippines. The prevalence of CLL increases with age, so it occurs most often in elder patients, just like our patient who is 70 plus years old. So again, there is accumulation of genetic abnormalities in more mature lymphoid cells. There is clonal division of neoplastic B lymphocytes within lymph nodes. Because of the slow process of neoplastic cell division, patients are actually asymptomatic at initial presentation. However, with continued cell division, B cells eventually spill over to the peripheral blood. Patient will eventually have weight loss, malaise, fatigue, night sweats, lymphocytosis, and because of the lack of functional B cells, the body's ability to produce antibodies decreases, and there is hypogammaglobulinemia, leading to increased risk for infection. Eventually, neoplastic B cells continue to divide within the lymph nodes. This leads to lymphadenopathy. They continue to infiltrate the spleen and the bone marrow. So we have bone marrow hypercellularity, splenomegaly, leading to eventual anemia and thrombocytopenia, again leading to fatigue, shortness of breath, and bleeding tendencies. So in patients with CLL, it is important to do a hematopathology review of the peripheral blood smear, or if we got a lymph node or tumor or tissue diagnosis, then again, a paraffin block of that or a bone marrow biopsy. Flow cytometry of the blood is enough to diagnose CLL, not necessary to do a bone marrow biopsy, but it's also okay to do one. The diagnosis of CLL requires the presence of monoclonal B lymphocytes in the peripheral blood. So again, essential to do history and PE, palpate the lymph nodes, palpate the spleen. These are important parameters and the CBC as well to tell us if treatment is indicated in our patients. So CBC, a complete metabolic panel including LDH, and the following tests. So this is the CLL staging systems. Some patients who are RISE0 and BNA-A, who are asymptomatic, who do not have adverse cytogenetic markers, can actually be just monitored and not treated immediately. Patients who are RI4 and BNA-C usually require treatment upfront. So for patients who are previously untreated, best really to enroll patients into a clinical trial prior to initiating therapy. We should assess TP53 status by CLL FISH and TP53 mutation testing. So in our setting, I usually use a FISH test to check for TP53. If the TP53 mutation is present, then I try to start with a BTK inhibitor with or without obinutuzumab. If there is no TP53 disruption, we can check for IgHV mutation and then see if the patient is fit or unfit in the following treatment options. So before we end, there is one particular issue with leukemias, and this is the hyperleukocytosis and leukostasis. So hyperleukocytosis is when there is a total blood cell count greater than 50 or 100. There is not a clear cut number. It really depends on the type of leukemia that is present. Leukostasis, on the other hand, is also called symptomatic hyperleukocytosis and is a medical emergency. It is most commonly seen in patients with AML or CML in blast crisis. It has an extremely elevated blast count with symptoms of decreased tissue perfusion. Pathologic diagnosis is made when white cell plugs are seen in the microvasculature, and the clinical diagnosis is made in a patient with leukemia and hyperleukocytosis presenting with respiratory or neurological distress. Prompt treatment is indicated since if left untreated, the mortality rate is approximately 20 to 40%. So per kind of leukemia, it's actually quite different. In AML, 10 to 20% of patients newly diagnosed will present with hyperleukocytosis. It usually affects the myelomonocytic, monocytic, and microgranular variant of APL, and typically affects patients with white blood cell counts over 100. ALL, usually these are 10 to 30% of newly diagnosed cases. Highest incidence is in infants, patients between 10 to 20 years old, males, and a T cell phenotype. However, it's not as common as tumor lysis syndrome in DIC, which are more common in ALL. In patients with CLL, symptoms of leukostasis are actually rare unless the white blood cell count exceeds 400. For CML, these patients typically present with leukocytosis and the median white blood cell count diagnosis is actually 100. And these are comprised mainly of segmented neutrophils, metamyelocytes, and myelocytes. Hence, leukostasis is actually uncommon in patients in chronic phase, but occasionally can be seen in patients in blast crisis with very high blast counts. So how to manage leukocytosis? We should improve intravascular volume, enhance renal blood flow, and promote urinary secretion by doing vigorous hydration of about 2 liters per meter squared per day with careful monitoring of fluid balance. So that's most important, hydration. And then control your uric acid production using allopurinol or rasburicase. You do urine alkalinization using sodium bicarbonate. And of course, reduce the number of circulating blast cells to prevent multiple organ injury. A rapid reduction in the number of circulating blast cells can be done by induction chemotherapy, hydroxyurea, and leukophoresis. So in summary, we have discussed the following. So when you are presented with an elevated white blood cell count, check the peripheral blood smear, check for other signs and symptoms that may point to a hematologic malignancy, do appropriate workup, which usually includes morphology, flow cytometry, cytogenetics, and molecular testing. Decide on the appropriate treatment based on your clinical diagnosis, comorbids, and of course, patient preference. And lastly, hyperleukocytosis is a medical emergency and must be treated promptly. I hope you learned something new today and may use this in your practice later on. These are my references. Thank you very much for listening.